and I'm really very pleased and honored to introduce Professor Joanna Moncrieff as our next speaker. Professor Joanna Moncrieff graduated from the University of Newcastle upon Tyne in 1989 and completed her psychiatric training in London and Southeast. For 10 years, she was a consultant for a psychiatric rehabilitation inpatient unit, helping people with severe and long-lasting mental health problems. She also has been working in various community mental health services in Northern East London. Professor Joanna Moncrieff teaches and does research at University College London. She is a co-chair and founding member of the Critical Psychiatry Network. Professor Moncrieff critically examines the pharmaceutical industry's influence and challenges the conventional view of mental disorders as brain diseases. Her interest in drug treatment led her to question the prevailing disease-centered model of drug action, which is based on the assumption that drugs work by reversing a hypothetical abnormality or chemical imbalance. Instead, she proposes the drug-centered model, emphasizing how drugs affect the body and brain and alter feelings and behaviors. Understanding the difference between these two models, I have to say, was very useful in my own clinical practice. So therefore, I'm very interested in Professor Joanna Moncrieff's works, and the floor is yours. We are ready to listen. Welcome.
Thank you, Paulius, and thank you for inviting me to this amazing sounding day of talks and discussion. So I'm very happy to be contributing to it. I'm going to share my screen and show you my presentation. Okay, so unless someone shouts out, I'll assume that you're looking at my slides. So I've called my talk Myths about Chemical Imbalances and Chemical Cures. And I'm going to talk to you, I'm going to show you, I'm going to present to you my views about the nature of psychiatric drug treatment, and then think about how those views apply in particular to antidepressants and also to the subject of suicide. So, and actually before I start, I'm going to say that I think my overall view is that I think some psychiatric drugs can be useful in some situations, but we fundamentally misunderstand what they do. Okay, over the last few decades, there has been a massive increase in the prescribing of antidepressants in particular, but also in the use of other drugs for mental health problems. In England now, almost 1 in 5 people take an antidepressant, and in the United States, around about the same proportion take some sort of medication for a mental health problem. And the use of antidepressants and other drugs of this sort has been accompanied by the message that depression and other mental health problems are due to chemical imbalances in the brain. So the chemical imbalance theory was an integral part of the marketing of the SSRIs when they were introduced in the 1990s. This is a pamphlet produced by the makers of Prozac, Eli Lilly, which tells people that serotonin, an important chemical found in the brain, is linked to depression. This message was also disseminated by professional organizations such as the American Psychiatric Association. As late as 2023, that's this year, they were telling people that differences in certain chemicals in the brain may contribute to symptoms of depression. This is a famous advert for the antidepressant Zoloft that gave the same message and was widely seen in the United States and all over the world. And it told people that although the cause is unknown, depression may be related to an imbalance in the natural chemicals in the brain, and Zoloft works to correct this imbalance. So this marketing campaign was very successful, and a large majority of the general public, as measured in surveys, came to believe that depression has been proven to be caused by a chemical imbalance. These are the results of surveys that show that. Now, it had been suggested before, but in 2022, we showed clearly that the serotonin theory of depression is not proven. So we published this, what's called an umbrella systematic review of the evidence. And these were our conclusions. We got together all the research on all the main areas of all the main different types of research that have looked at possible links between serotonin and depression. And we found that there was no evidence that depression is associated with lower serotonin concentrations or activity. There is a little evidence from some studies that it may be associated with higher serotonin levels, but the evidence was inconsistent and the results were likely to be false positives or due to the consequences of antidepressant use. There was some evidence that taking antidepressants is actually associated with lowered serotonin, not higher serotonin. And the genetic studies that we looked at were convincingly negative. They were very large and well conducted, and they showed no evidence of links between serotonin genes and depression, but a very strong association between depression and adverse life events. So what are the implications for our thinking about antidepressants? Well, first, we cannot say that antidepressants are reversing an underlying brain abnormality or targeting an underlying biological mechanism that produces depression or symptoms of depression. There may be other biological mechanisms apart from serotonin, but these have not been established either. And therefore, we have to consider other possible ways that antidepressants might be having their effects, such as through amplified placebo effects or emotional blunting. And these other ways have different implications for deciding whether antidepressants are useful and for thinking about how they might be harmful. So this leads me to my work on models of drug action that Paulius mentioned. So the conventional way of understanding psychiatric drugs is what I have called the disease-centered model. And this is the idea that drugs work by correcting an underlying abnormal brain state. And most drugs in general medicine work this way, including treatments for asthma and painkillers. They may not treat the ultimate cause of the disorder, but they work by targeting the mechanisms that produce symptoms. But there's another way that drugs may be working when we think about the drugs that we use for mental health problems. And that is what I have called the drug-centered model. And this is the idea that drugs change the normal state of the brain and body, and that these changes result in changes to mental activity, which are temporarily superimposed on underlying thoughts, feelings, and behavior. And an example of this is the use of alcohol. We talk about how alcohol can, in English, we have an expression that you can use alcohol to drown your sorrows. I don't know if there's a similar expression in Lithuanian, but the idea is that when you're under the influence of alcohol, the alterations it produces temporarily suppress your underlying feelings of depression or sadness. But alcohol is not doing that by targeting the underlying mechanisms that produce those feelings. So the drug-centered model highlights the fact that the drugs we use for mental health problems are what we might call psychoactive drugs. That is, they are drugs that change the normal state of the brain and thereby produce changes in sensations, mental activity, and behavior, as well as physical functioning. The changes can be pleasant, as in the case of recreational drugs, or unpleasant, as in the case of psychiatric drugs such as the antipsychotics. And it is these changes that can temporarily override mental distress or other abnormal or unwanted mental states or behaviors. But these changes can also have other consequences. They can cause dependence and withdrawal and have predictable and unpredictable harmful effects. So just to say, so the drug-centered model emphasizes that there is no categorical distinction between recreational drugs and psychiatric drugs. They are all drugs that affect the brain in one way or another and consequently change our mental states and behavior. So what caused the drug-centered model to be replaced by the disease-centered model? Because historically, drugs were actually understood according to a drug-centered model. If you think, we used to talk about tranquilizers, but now we talk about antidepressants and antipsychotics. So this transformation did not happen because of scientific evidence. The evidence that we have for the effects of psychiatric drugs comes mostly from placebo-controlled trials that do not distinguish between a disease-centered and a drug-centered model. And there is little other evidence that could confirm that any drug in psychiatry works in a disease-centered way. And unless there is good evidence that a drug works in a disease-centered way, we should assume that they work according to the drug-centered model, because we know that they do have brain-changing properties and therefore mind-changing properties. So I just want to think about what a drug-centered understanding, what a drug-centered model means for our understanding of antidepressants. So first of all, if we take a drug-centered approach, we need to know what physical and mental alterations antidepressants produce. And then we need to think about whether these are helpful in people with depression. Now, antidepressants come from many different chemical classes. Some have quite subtle effects, some more obvious effects. Many of them produce lethargy, tiredness, weight gain. Some produce insomnia. Some produce irritability and tension, especially in younger people. And this may be related to an increased risk of suicidal behavior, which I'll come back to. They are not pleasant to take generally, so they are not abused or used in a recreational setting. And most of them seem to have this property of emotional blunting. Someone in one study I did described this as feeling distanced from life. And they also very commonly produce sexual dysfunction, which may be related to the emotional blunting. So there's been some debate about emotional blunting recently, and some people have said it's due to depression, not antidepressants. But there is very consistent evidence that antidepressants blunt emotions, both positive and negative emotions. There are consistent descriptions from people who've taken them. And there is also recently published one study of antidepressants in volunteers, which also found that they appeared to reduce motivation motivation that was produced by rewards. And these alterations, this emotional blunting, may reduce depression scores in controlled trials of antidepressants. But antidepressants may also produce amplified placebo effects, which may account for the results of these trials. So the question is, are they actually helpful? You will have seen many headlines claiming that antidepressants work and that it doesn't matter how they work, they just work. But do they? The average difference in placebo-controlled trials between the antidepressant and the placebo is 2 points or less on the Hamilton rating scale for depression. So here you can see, this is the placebo and drug group. This is a typical baseline score, and this is the total Hamilton score. So the difference here is very small. And when you look at that difference and compare it to the clinical global impression scale, which rates people according to their level of improvement, you find that it's less than the 3 points difference that you need to register any change, and very much less than the 8-point difference that is equivalent to showing minimal improvement. But do antidepressants work for some people, maybe? A meta-analysis published in 2022 claimed this. Now, overall, this meta-analysis found a difference between antidepressants and placebo of 1.75 points. But an exploratory and very complex modelling procedure suggested that there were 3 types of outcome: good, middle, and poor outcomes, and that people on antidepressants were more likely to be in the good outcome group, and people in the placebo were more likely to be in the poor outcome group. But in fact, most people were in the middle outcome group. It did not identify subgroups of people who responded better or worse to antidepressants. And a similar analysis found a 2-group pattern instead of a 3-group pattern. So this is a very tentative and complex modelling analysis that is not a conclusive exercise. But even if this small difference, even the small difference that is found between antidepressants and placebo may not be a real difference due to unblinding effects in antidepressant trials. Now, unblinding means that unblinding is when people can identify whether they have been randomized to the active drug, the antidepressant, or whether they have got the placebo. Mostly this is not tested, but when it is tested, some studies find evidence that people can detect what they're taking. For example, the Kranzler study of fluoxetine in people with alcohol problems showed that 80% of people allocated to fluoxetine correctly identified their allocation, whereas you would expect this to be 50% if they were guessing randomly. And we know that what people guess they are on has a strong impact on their outcome. So this is the results of a trial comparing sertraline, hypericum or St. John's wort, and placebo in people with depression. And the results on the left are the actual findings of the trial. So people on sertraline did a little bit better, but there was actually no statistically significant difference between any of the groups. But if you analyze the results by what people guessed they were on, there is a very substantial difference. And in this particular trial, people didn't guess correctly. So the guessing didn't influence people's outcomes. It didn't influence the actual outcome of the trial. There's even less evidence for the effects of long-term treatment with antidepressants. Most trials are short-term, and long-term treatment or relapse prevention trials are confounded by the withdrawal effects that occur when people are taken off antidepressants and transferred to placebo. And you've heard about the withdrawal effects from Michael Hengartner in the last talk. So this just shows you that what happens in these withdrawal trials is that people who are put on the placebo relapse quite rapidly after they're taken off their previous drug and put on the placebo. People who continue on the drug relapse at a more steady rate, and the two rates come together. So these sorts of trials do not show that long-term treatment in itself is beneficial. Then, of course, when we think about antidepressants, we have to consider their adverse effects. They are probably not as dangerous drugs as things like antipsychotics, but they do cause physical dependence, and around 25% of people can have really severe withdrawal symptoms, and these can last for months and years. They commonly cause sexual dysfunction, and occasionally it appears that this dysfunction can be persistent. And these effects are only really coming to light over recent years because of patients highlighting them, because the research that we have done on antidepressants has not looked in detail at the consequences of long-term use. And then they have some rare but serious side effects, including suicidal behavior in young people, which again we'll come back to. So just to conclude on antidepressants, there's no evidence that antidepressants correct a biological abnormality. They alter normal brain chemistry and functioning in ways we do not fully understand. The evidence for beneficial effects is minimal, and they have under-researched and underappreciated serious and common adverse effects with long-term use, including protracted withdrawal and persistent sexual dysfunction. Okay, what about antidepressants and suicide? We are often told that antidepressants save lives. This is a newspaper headline from the United Kingdom claiming that antidepressants saved my life after my diagnosis. On the other hand, most people have also heard that antidepressants may be linked to an increased risk of suicide. So a recent BBC programme highlighted this risk and featured the very sad story of a young man who'd taken his own life while he was after being started on antidepressants. So what is the evidence? The argument that antidepressants reduce suicide is based on the idea that they effectively treat depression. But we have just seen that actually the evidence suggests they are not effectively treating depression. They are barely different from a placebo. Ecological data that has looked at suicide in populations and tried to look at trends and relate them to antidepressant use is inconsistent and confounded by many factors. Data from randomized controlled trials shows a slight increase in suicidal behavior in suicide attempts and suicidal ideas in young people. And there have been no randomized controlled trials of antidepressants designed to test their anti-suicidal effects specifically. Suicide is affected by major social events and not prescriptions, I would suggest. So this is a graph of suicide in the United States in the 20th century. And as you can see, it goes up in periods of economic depression and down when there is a world war, as in 1914 to 18 and the 1940s. And there has been a long-standing trend of a decline in the suicide rate in older people over the 20th century, starting long before antidepressants were introduced, which may be to do with the improved condition of life for older people, with old age pensions being introduced. This paper, which was published in the British Medical Journal, is an example of the misinterpretation of ecological data. So this paper claimed that reduced antidepressant prescribing, which had occurred because of various warnings, had increased suicide attempts in young people. It found no association with completed suicide, which had continued on a downward trend. But what they did in this paper is they counted all drug poisonings as suicide attempts, when data actually showed there was a significant increase in accidental poisonings in young and older people. And this was done at the height, this study was done at the height of the opioid crisis, for example, when there were a lot of accidental deaths and overdoses. And other more valid measures of suicide attempts did not show an increase during this period. But this was, I'm just using this as an example of how data can be misrepresented. This was published in a very influential journal, and it claimed that it found evidence that reducing antidepressant prescribing was connected to an increase in suicide attempts. What about evidence that antidepressants increase the risk of suicide and suicidal behavior? Well, the association between SSRIs and suicidal behavior was first noted in some case studies that were published in the 1990s. And then there have been various meta-analyses, some of which have shown evidence that antidepressants increase the risk of suicidal behavior to a small degree, or suicidal behavior is rare. The increase can be quite a large one, but there are still not many events. The strongest evidence is definitely in children and young people, where meta-analyses do seem to have consistent findings that there is this small increase. The best one of these meta-analyses was done by Sharma et al., also published in the British Medical Journal. And this was a good study because they used clinical study reports as well as published data. And they found an increase in suicidal ideation and suicide attempts in young people on antidepressants. They also found an increase in aggression in young people on antidepressants, but they found no differences in adults. But they did also find that there was frequent underreporting of suicidal behavior and misreporting. What about other drugs and the relationship between other drug treatments and suicide? It has frequently been claimed, for example, that lithium has specific anti-suicidal properties. For example, papers have said that these properties are proven, that they represent that there is unambiguous evidence that lithium has anti-suicidal effects, that it has intrinsic anti-suicidal properties. Lithium is recommended as a preventive treatment for suicide by some guidelines, such as the Veterans Affairs guidelines published in the United States. And some people have even suggested it should be added to drinking water to reduce suicide. Now, an influential meta-analysis published in 2013 claimed that there was evidence from randomized controlled trials that lithium reduced suicide. But I repeated that meta-analysis with a student at University College London, where I do my academic work, which we published in 2022, and that found that there was no evidence from randomized controlled trials that lithium prevents suicide. So here you can see the overall estimates of effect, which it's quite difficult to to do these analyses because the numbers of events are so small. So you have to use clever statistical techniques to get an overall effect. You'll see here that there is one trial that stands out a bit, and this trial, in this trial, there were 3 suicides in the control group, but none in the lithium group. So this trial has often been quoted as evidence that lithium may have anti-suicidal properties. The trouble is, there were problems with this study. So first of all, the suicide rate was lower than they predicted. Recruitment was difficult, and they struggled to get people to take their lithium. And because of this, they broke the double blind if people's lithium levels were not high enough, or if they thought they were at high risk of suicide. And if that was the case, they were given additional monitoring. So a lot of people who were on lithium got extra monitoring because they weren't taking the lithium properly. And we know that people who have increased monitoring in itself can reduce suicide. In any case, the number of suicides was very small, and this study actually found no difference in rates of suicide attempts. In our meta-analysis, there was no difference in any of the studies or overall in suicide attempts. So, to conclude on drug treatment and suicide, there's no evidence that any sort of drug treatment for any disorder reduces suicide or suicidal behavior. The only trials that are specifically aimed at testing anti-suicidal effects of drugs have involved lithium and are negative overall. And there's evidence that antidepressants, far from reducing suicide, actually increase the risk of suicidal behavior in young people, but not adults. But it is still rare. So I'm about to wind up, and we'll have plenty of time for questions. But I just want to ask this question and try and answer it. How is it that we have misunderstood psychiatric drug treatment so badly? Why is it that most people, most psychiatric textbooks, most psychiatric academics believe the disease-centered view of drug action, even though there is no evidence to support it? I think this is because of a combination of interests, of vested interests. The psychiatric profession want to believe that the disease-centered model is correct because they want to believe that they have sophisticated and targeted medical treatments that helps to bolster their status and their medical credentials. The pharmaceutical industry has used the disease-centered model to persuade people that its drugs are targeting a disease rather than doping them up. And that has been a very effective way of marketing antidepressants in particular. And then, of course, there are very many people who are anxious, insecure, desperate, distressed, lonely, disappointed, and who are looking for help and looking for support and vulnerable to being told, to being given misinformation about the nature of psychiatric drugs. So those are my books, which will contain references and more information if you're interested. And there are also many papers by me on the internet that you can download for free. That's all I have to say for now, and I'm happy to take some questions.
Okay, so thank you very much for the presentation. And as you could expect, we have lots of questions, lots of reactions. Some people are commenting that they want to thank you very much for the presentation. And then I go for the questions. So first question is, could the author comment on the recent publication in Nature, which is the response to her umbrella study with an entirely different conclusion, that the methodology of umbrella review is inconsistent with the substantial bias created by the author's chosen quality criteria and selective reporting?
Yes, I'm very happy to comment on that. So the reaction to the serotonin paper was quite extraordinary. The public didn't know that that the serotonin theory of depression was not proven, and were shocked and distressed by it. And many people were angry and felt they had been misled. And some people were angry at me because they felt they didn't want to know this. The professional reaction was very muddled. So first of all, people said, psychiatrists said, we knew that all along. This is not important. It's not news. We already knew that the serotonin theory of depression wasn't established. So that was the first response. And they also said, but it doesn't matter because there are all these other theories about depression and all these other theories about what antidepressants might be doing. And so please don't worry about it. Just carry on as normal, taking your antidepressants. And then a group of people got together to write what was initially a letter to the Journal of Molecular Psychiatry and then was published as a commentary. And they made a lot of criticisms of us, of our various aspects of our methodology, which I'll come back to. But what I want to say is that they did not actually challenge our conclusion. Their conclusion was there was some evidence of a link between between depression and serotonin from some studies. Now, we would also say, yes, there was a little bit of evidence from a few studies of a link between depression and serotonin, but overall, there was not conclusive evidence of a link between serotonin and depression. So I don't think that their conclusions were actually that different. And they were highlighting some minor results for example, in the tryptophan depletion studies. They were highlighting effects in patients, whereas we had highlighted effects in volunteers. These studies were set up to be done in volunteers, and that's why we had highlighted those. In any case, more recent studies have not confirmed the effects in patients. They made a number of criticisms of our methodology. They made claims that were designed, in my view, to discredit us, such as that we had made mistakes and errors. We had not made mistakes and errors. One of our authors is a well-known expert on doing systematic reviews. That is what she does for her living all the time. And we had actually done the review very thoroughly, following all the recommended procedures and guidelines. And we had been absolutely transparent about the decisions we had made and what we had done. You can always make different choices when you do a systematic review. You can choose to do your quality rate, you can choose what quality scale to use, how to do your quality ratings in various different ways. And that is what Juha and his colleagues were criticizing us for. They were criticizing us for choices we had made, which you can argue with, but we had, I think, given a perfectly good justification for all the choices we had made. But they were certainly not mistakes. That was not that, to say that they were mistakes is not a fair assessment of our paper. So I hope that answers the question. I could go on about it for longer. It was, maybe I'll just say this. The paper itself, the commentary itself, was clearly part of a campaign to try and discredit us and try and, I think, confuse people about the issue, so that people wouldn't realize that it was as simple and straightforward as there is no evidence, or no conclusive evidence. So that people would go on believing that that there is some evidence that depression has biological origins. So it was part of a campaign which they press released the commentary. They released hundreds of tweets on Twitter. They had a hashtag. They all joined in with tweeting this. And as I say, it was clearly designed to discredit the paper, discredit the authors. And in my view, that was in order that people would not realize that there is no proof that depression is a biological condition.
Okay, so thank you very much for a very comprehensive answer. Another question. It seems that antidepressants on their own aren't that helpful. But what about antidepressants plus therapy, talking therapy, psychotherapy? Could it be that the problem is that people are being put on medication by GPs, but no other support is being provided?
Well, that's why the placebo-controlled trials are important, because it looks from the placebo-controlled trials as if the medication is not really that relevant, and the effect that you get with medication is actually a placebo effect. And the trials of combination therapy do tend to show that the combination of antidepressants and therapy is better than either one on their own. But I don't think those trials can establish that antidepressants have a real pharmacological effect. There's still the interpretation that actually this is a placebo effect. And sorry, and I'd just like to say something else on that. So there are different ways of thinking about the relationship between antidepressants and therapy. So on the one hand, there is the idea that antidepressants might help people get a little bit better and therefore be more amenable to therapy. As I said, I don't think the evidence is there that they do help people get a little bit better. So I'm not sure that's the case. Then there's another idea that antidepressants may make therapy less effective, partly because they are suppressing people's emotions, and you need to be in touch with your emotions to actually benefit from therapy. And also partly because many people taking antidepressants have absorbed the message that there's something wrong with their brain. And if you believe there's something wrong with your brain, and every day you take a pill that reminds you of this, then you are likely to be less able to make use of therapy, because you will be more pessimistic about you will have less confidence in your ability to make changes in your life.
Less confidence and maybe less agency that you are able to do something, because it sort of depends on your brain. Okay, one more question. So what kind of treatment you suggest for depressed patients, for example, severely depressed patients or medium severity, severely depressed patients, because psychotherapy also not working for this kind of patients, for this group of patients?
Yeah. So first of all, I think we need to move away from thinking of depression as a medical condition that requires treatment. I think we need to think of depression as an emotional reaction, and that sometimes some people need support and care. You know, and the most important thing is that we don't give people treatments that actually end up making them worse. So when we are thinking about how to help people, we need to work out why they are depressed. What is their depression? What is their emotional state a response to? And that's where therapy can be helpful, because sometimes people don't know why they are depressed, and it may take a while for them to work that out. So fixing the things that are wrong in someone's life, or helping them to fix them, is the most important form of treatment, or the most important way of helping people, in my view. Now, it's true that there are some people who, you know, are quite severely depressed, with whom it is difficult to do psychotherapy. And for those people, I don't think there is any fantastic treatment out there. I think what we need to do is support and help people and care for people in that situation, and make sure people are safe, and then gradually help people to re-engage with life again, introduce them to, you know, accompany them and introduce them to, you know, new activities, and expose them to nice things in the world to help them get over their depression. So there is no magic bullet, in my view. There is no easy solution, but it's very important that we don't give people wrong solutions just in order to do something. We can do a lot of harm by just giving people things because we think we must do something. Sometimes it is better to just be with someone and support them and look after them and keep them safe.
Okay, thank you. Lots of questions are coming and coming, so I have to choose maybe those that are not repeating each other. So one question is, actually, it's more like of a statement. I think people working in the field with actual clients would highly disagree with this particular point of view. So maybe you could comment from not only from the, you know, theoretical academical point of view, but you actually also work with actual patients. So how could you comment on that, well, what you see in your clinical practice?
So what I see in my clinical practice is entirely consistent with the views that I've put across, and I've worked for many years in clinical practice, and I think what this questioner is highlighting is that we can see things in very different ways. I remember when I was a junior psychiatrist, I remember wondering why people were so positive about drug treatments and how it was that other people thought they were so helpful, because I didn't see that with my patients. I didn't see, sometimes people got better, of course, but often, usually when they got better, there was another explanation. It wasn't just that they had started the antidepressant. There was always another way of thinking about it, another way of explaining it. So I just simply didn't see the benefits that the textbooks said and my teachers said that antidepressants had. And when I looked at the effects of antipsychotic drugs, for example, what I saw was a lot of very sedated people. Now, sometimes when someone is very psychotic and unpredictable and agitated, being sedated and tranquilized is a good thing. But nevertheless, I didn't see people who were cured. I saw people who were tranquilized. So I think what you see is colored by what your views are. And some people will continue to see miraculous effects of drugs and believe in the disease-centered model, but some people will not see that. And certainly I don't see that. And I know many, many other colleagues who do not see those beneficial effects.
Okay, a bit different question. I experienced PSSD, post-SSRI sexual dysfunction, as a antidepressant withdrawal symptom. Never had any problems with libido prior or on antidepressants. Is it naive to hope it's going to diminish with time? I've seen BBC documentary, but still hope it's the question of time.
So I'm really sorry to hear that. This is a really tragic complication of antidepressants that is coming to light now. And just to be clear with people in case they didn't understand the question. So this is the question, this is the effect of having persistent sexual dysfunction after you have stopped taking your antidepressants.
That's what I understand.
Yeah, and it is, it can involve various sorts of difficulty, including low libido, but also genital numbing, and problems with having orgasms and erectile dysfunction. So it can involve the whole gamut of sexual difficulties. So yes, I know there are certainly cases of PSSD that have got better. So please do be hopeful. And also it is definitely the case that the protracted withdrawal symptoms that some people seem to experience after stopping antidepressants also get better with time. It can take a long time, but most people in my experience do get better. So please remain hopeful, because it must be a terrible situation to be in. But we don't know. I mean, I can't say this based on evidence. We don't have data on this, but my inclination is that most people will get better with time.
Thank you. Another question. Pain isn't opioid deficiency, but opioids, for all their faults, do a great job of treating pain. It works the same way with serotonin and antidepressants. Wouldn't you agree?
So, so I often use the example of opioids to illustrate the disease and drug-centered model, actually. So thank you for drawing my attention to this. So you are right that that opioids and also paracetamol and aspirin and other painkillers do not treat the original cause of pain, but they do act on the mechanisms, the biological mechanisms that produce pain, and that's how they reverse it. And drugs like aspirin and paracetamol do not have any psychoactive or mind-altering effects. They just work on those physical pain mechanisms in what I would say is a disease-centered way. Opiates, however, have some action on pain mechanisms, but they are a psychoactive substance. So they are also changing your mental state, your normal mental state. And the changes that opiates produce include feelings of emotional indifference, a sort of emotional numbing, although different in nature from that produced by antidepressants. And I have encountered people who have taken opiates when I was doing my medical training, who will tell you that they still have some pain, but they don't care about it anymore. And that aspect of the opiate effect is what I would say is a drug-centered effect. And so that part of their effect is equivalent to the effects of antidepressants, the emotional numbing effects of antidepressants, the tranquilizing effects of antipsychotics. But the effect on physical pain mechanisms, I would say, is different, because we do not have evidence that SSRIs or any sort of psychiatric drug is targeting the biological basis of symptoms of depression.
Okay, thank you. Another question is about endogenic, so-called endogenic depression or biological depression, that it exists, and it's not enough then to just support patients, and we use different biological treatments, maybe electrostimulation or not only antidepressants. So what do you make of endogenic and biological depression at all? What is that?
So, I mean, we don't have any evidence that any sort of depression is caused by biological mechanisms. It just does not exist. I've analysed all the evidence on serotonin. There are no studies on serotonin dysfunction specifically in people with very severe depression. So we don't have evidence about it. It may be that it's biological, but we haven't discovered that yet. We cannot say that it is the case that there is a biological sort of depression. And therefore, any treatment that we give to people who have severe depression is not targeting the underlying mechanism. It is altering their brain in some way and affecting them through altering and changing the normal state of their brain. And we don't understand the full consequences of that. And so we have to be very careful about doing it. And that is just as true if someone is severely depressed than if someone is more mildly depressed. So I would say that even if someone is severely depressed, we are not justified in giving them ineffective treatments. Now, we could have another whole debate about electroconvulsive therapy and whether that is effective or not. I would suggest that, like my drug-centered model, ECT causes physical and mental brain alterations that cause an altered mental state that temporarily overrides people's underlying feelings of depression, people's underlying emotions. The trouble is, so ECT, yes, does have temporary effects of lifting mood for some people. The trouble is, its effects do not last. They are temporary, and within a few weeks, people are back to the state where they would have been, or within a few weeks, people are probably back to where they would have been anyway. So my personal view on ECT is that it's not justified because it's too short-lived. And because it is, again, not really targeting the mechanism of depression. It's just basically putting someone into a post-epileptic fit state. But there is an argument, which I will accept, that if someone is really dangerously depressed and not eating and drinking, then maybe you should try ECT. Personally, I think in that situation, you can have a member of staff next to the patient, feeding them little bits of food and water, and you can manage to keep them alive in that way, and that ultimately is better than giving them a brain procedure that we don't, whose effects we do not fully understand.
Okay. I think this question that I will read now was addressed in some way, but just maybe you will have something else to add. How atypical antidepressants fit into the picture? Example, dopamine, noradrenaline centered, bupropion, esketamine, microdosing of psychedelics that has been gaining increasing interest.
So the thing is, we need to understand what sort of drugs all these things are. And they are very different sorts of drugs. Antidepressants come from very many different chemical classes. So bupropion, for example, is a slightly stimulant drug. It has a different sort of effect from SSRIs and from tricyclic antidepressants. I still can't see, I still don't think any of the alterations it produces are particularly useful for someone who is depressed, but it is a slightly different drug with a different profile of effects. Esketamine is basically a form of ketamine. That is a strong psychoactive drug that makes people, gives people a sort of semi-psychedelic experience. So some people may gain some insight, learn something from having a psychedelic experience, but other people will not. Other people will find it unpleasant and scary. And there are other ways, probably safer ways, to learn things and gain insight into ourselves and our moods, such as traveling, dancing, singing, climbing mountains. There are many other experiences that people have that teach them life lessons. And my concern about psychedelic therapy is that it's just basically become a money maker, and it's being used to persuade desperate and vulnerable people that there is an answer out there, and that all they need to do is come in for this nice trip, and then they'll be okay. Of course, it's not like that. It doesn't cure them. So then they have to go back for another one and another one and another one. Esketamine is already designed as a long-term treatment. And just as with antidepressants, we have no data, no research, no knowledge about the long-term consequences of using these substances.
Some could argue that some of the ways you mentioned, like dancing, traveling, and so on, could not be accessible to people who are depressed, severely depressed, moderately depressed.
If people are severely or moderately depressed, if people are severely depressed, are they really going to be able to process the effects of having a psychedelic experience as well? I'm not sure. I think in that situation, what people need is love and care and attention, and very gentle sort of reintroduction to the world, not a major, weird psychedelic experience.
And the last question from me, it's I could see from the comments and you, I'm sure you experienced that many times when you say things like that, although you base them on studies, on evidence, on umbrella review and other things, you still receive a lot of not criticism, but blaming of incompetence, of conspiracy theories, of hatred, I would say. How do you deal with that?
It's hard sometimes. Trying to turn off Twitter is a good start. Yeah, but what an interesting point. This is clearly. I mean, I try and stand back and see it as interesting that this makes people so angry. What does that tell us, that people get so angry? I think it tells us a number of things. I think it tells us that psychiatrists are very insecure and defensive. I think it tells us that people who are using antidepressants and other drugs are desperate, and when they find out they've been lied to, they need to be angry with someone, and sometimes that's the people who lied to them, but sometimes it's me. And I think that's also a consequence of the fact that when people are persuaded that there's something wrong with their brain chemistry, that changes their whole perception of themselves, their whole understanding of who they are. And then if someone comes along and says, no, that's not true, they have to, that understandably leaves people feeling very confused and not knowing who they are anymore. So there are many. I try and look at the reasons that motivate people's anger, because I think they are interesting and that we should learn from them, that they can tell us something that will help us actually have a better approach to these problems.
So thank you very much. We are a little bit over the time, but there were so many questions that people wanted to ask you. And it's a rare occasion that we have this frank discussion about the antidepressants and, about the withdrawal effect that we, practically had no discussion, public discussion whatsoever in Lithuania. So I think that's very much important. And thank you for being here.
Thank you, Vilnius. It's been a pleasure. Enjoy the rest of the conference.
Thank you.